two orthogonal planes like any other joint. So we can't have lateral because that will obscure everything. That's why we have two views. So we can see erosions because you may miss that. But there's another point as well. So look at that. We're looking at the metacarpal heads. Okay, where would you like to see the erosion? This is the metacarpal head. You want to see on this side or lateral side or okay. Very good. So absolutely. Because ulnar side flattening or sometimes there's irregularity on the ulnar side of the metacarpal head, and that can be mistaken as erosions. So in real life, we always look on the radial side because that's where the erosions usually occur, or they can be easily picked up. On the medial side, they can be missed with the normal. So remember that ulnar side can be normal because there's N in it, okay? And the radial side where we should look for erosions in the metacarpal head. And we're not talking about the feet, we're talking about the hands. So if you're looking for the hand X-ray, so when you're doing a ball catcher view, you can see these erosions better as compared to the normal dorsal Palmer X-ray or PAV or APO, whatever you want to call it. Okay. So always look on the radial aspect. Ulnar side irregularity can be normal. Ulnar, normal. Okay. Remember normal with the N. So we're looking at the X-ray. Uh, Patient presented with morning stiffness and pain in the hands. How would you work out? You go to the X-ray, you're looking at, you're reporting it. What you start looking for? Very good. Absolutely. You're looking for the distribution, if there's any abnormality, bone density, is any joint space narrowing, any erosions? Yeah, all these things. Very good. Okay. So, but we have to have a system that we want to just have a small system of looking at these things. We'll look at that in a minute. Okay. So we look at the distribution first. Okay. So overview. Go back, look at the X-ray. Okay, just have overview. Like we used to say, look at the bedside of the patient, look at the patient as a whole and see what's going on in there. So is any abnormality? What is the distribution of that abnormality? Very good. Okay. And then we'll look for, you mentioned, quite a few of you mentioned rest of the thing. We look at the morphology. And most of you have covered that. We're looking at the soft tissue swelling, starting from the outside inside. From outside, you see soft tissue swelling. We look at the osteopenia, joint space narrowing, subpondosis or erosions, okay, and calcification. So these are the generalized things you can look for when you start looking at the X-ray of the hand or feet. Okay. So first thing, distribution. So how will you look for on hands? We divided it whether it involves the DIP joints or PIP joints. Then we look at the MCP joints and then on the wrist joint. It doesn't matter, you can start looking from this side as well, but you should look at the both X-rays quickly from one side to other and compare what is going on in there and pick up if there's any abnormality and distribution. This is the earliest part you do when you look at the X-ray, to look at the distribution of any abnormality in the hands. Same goes with the feet. You can divide it into hind foot, midfoot, then MTP joints and PIP and IP joints. The main problems in the arthritis are in the forefoot. Hindfoot problems are rare because hindfoot joints are big joints. So most of the arthritis, as I said before, involve the small joints of hand and feet. Now, starting with osteoarthritis. So what is the commonest place in the hand and feet? Let's start with the hands. What is a common place for osteoarthritis? We're talking about the hand. No, wrist, just leave it for a minute. Yeah, very good. Okay. So osteoarthritis mainly involves the DIP joints. Okay. Can involve the PIP joints, but mainly distal joints are involved, so interphalangeal joints. It is a disease of distal part of the hand. as compared to rheumatoid arthritis, which is a disease of proximal part of the hand where MCP joints are involved. So always think of osteoarthritis involvement is due to mainly distal interphalangeal or interphalangeal joints. Okay, so are MCP's joints are involved? Yeah, they can be involved, and these are mainly second and third MCP joints. DIP joints mainly, or then can be second and third MCP joint. Okay, so what do we see? Look at the example now. We can see that even this is a small joint, there is uneven joint space loss. There is more loss in here and less loss on this side. And there is a loss of joint space. Look at the DIP joint of this side. Article cartilage, sorry, the joint space is maintained, but here uneven joint loss. And here you can see the undulating surface, marginal osteophytosis, more loss on this side, less loss on this side, and osteophytosis is more on one side. Okay, on the other side, you can see there's a cyst as well, maybe some unchondroma there, but look at the osteophytosis is more on one side. Okay, so you can see that even though it's a small joint, joint space loss is not symmetrical. It's quite asymmetrical within the joint, which is a hallmark of osteoarthritis. Of course, there is some soft tissue swelling and marginal osteophytosis there. This is very typical appearance. So what you see, asymmetrical joint space loss, I mentioned, osteophyte formation, which is again asymmetrical, subchondral cyst formation, probably I'll show you another exercise in a second. And most important negative point is that the bony margin is sharp. Okay, you can see the bone margin is extremely sharp, which is typical of osteoarthritis. So these changes, if I put in any other joint, if I say the knee joint, same thing happens. There's asymmetrical loss, osteophyte formation. There can be subchondral cyst formation, but the bone margin is soft. Remember this word, bone margin is sharp, because it's a disease of DIP or PIP joints. This will help us in differentiating from other conditions. Okay, let's look at this one. Okay, so this is uneven joint loss. People used to call it Gullwing sign, and they used to call it erosive arthritis. It is not erosive arthritis. Erosive arthritis happens when there's irregularity of the bone. We come to that in a minute, okay? So this is just the normal osteoarthritis of the DIP joint of the little finger, okay? Look at this one. Joint space loss is not that much, apart from maybe a little bit that one, but look at that, the subchondral cyst formation there, okay? But look at both. Look at the bone margin. It's very sharp bone margins. There is no fluffiness, no periosteal reaction, and there is some soft tissue edema. Maybe a little bit of soft tissue, not edema, thickening there. Maybe a little bit there, but definitely there around the index finger PIP joints. So two examples of osteoarthritis. This is subchondral collapse. We can see that in osteoarthritis. We can see that in advanced osteoarthritis of the knee joint or any other joint. So remember that asymmetrical joint loss, osteophyte formation, subchondral collapse, but the bone margins are sharp. Okay, another example similar to that as we saw before, there is subchondral collapse, subchondral cyst formation in the little finger, middle phalanx, and on the other side, a similar change, but no subchondral cyst formation. So this is osteoarthritis of the hands. So if you look on ultrasound, you can see that there is osteophyte formation, but no synovial thickening. Okay, you can see that the soft tissues are very clean, pristine margins on ultrasound. So that is very typical of osteoarthritis. We do not do it, but some patient with the extreme pain, we perform some injection just to reduce pain, which is a temporary measure. But you can see that the outline is very sharp. Now, as I mentioned, it can involve all the MCP joints, but mainly second and third MCP joint. But the most important thing is that there is no osteophyte formation. Okay, so joint space is reduced. Again, asymmetrical joint loss. Joint space is less loss, relatively preserved here, but on this side, on the radial side, is completely gone. but no osteophyte. This is a hallmark of osteoarthritis. Look at here. Not such. Look at the significant loss of joint space, but osteophyte is not very common. So, contrary to the other top end or DIP joints, osteophytes are usually not seen in the MCP joints. So a little bit of difference between the osteoarthritis of the DIP joints or PIP joints and MCP joint. Okay, so where does somebody mention that already? In the wrist joint, it typically involves the distribution of osteoarthritis in the wrist joint. Very good. First CMC, absolutely right. Okay, but what is this joint which my cursor is on? Sorry, I've lost my cursor. Is here? Yeah, STT joint as well. This is the scaphoid, trapezium, and trapezoid joint. We call it STT joint, where most of the arthritis starts. Okay, STT joint and first CMC joint, and it can vary. Sometimes, usually, it's more common in the first CMC joint, but usually it is, and it is also associated with STT joint as well. So STT joint and first CMC joint is the earliest places or the commonest places of arthritis in the wrist joint. And it is associated, it can be associated with subluxation. Okay, I'll show you a few examples. But most important thing to remember that this space, radiocarpal joint space, is preserved. So this joint is not involved in osteoarthritis generally. Okay. So look at a few examples. Let's start on the right side. There is arthritis in the CMC joint. There is a new bone formation or some loose body there, and it has subluxed. Very common in elderly patients, especially in females, subluxation of the first CMC joint. But look at STT joint. It is almost complete loss of joint space and subcondylar sclerosis here. But next thing we look at, radiocarpal joint is generally preserved. Okay, let's move over to the middle screen, okay, middle image. First CMC is relatively normal. But if we come to STT joint, there is significant joint space loss. Radiocarpal is preserved. Let's move on to the third one. There is significant subluxation, arthritis, and new bone formation, and maybe some debris in the joint. But STT joint is almost normal. So different variation can be seen in these patients, and they are both are sign of osteoarthritis. Can you not see all three images? Somebody said I cannot see all the images, but anyway, we'll see that next slide. Okay, so what is the summary? So maybe one person can, but the rest can see. Okay, so what is the summary of osteoarthritis of hand? So you can type it, what we learned so far, and I can cap on it. So what is the distribution? What is the distribution of osteoarthritis of hand and wrists? DIP joint or PIP joint, very good. STT joint at first CMC, very good, excellent. So what do we see? What is the morphology? Yeah, somebody mentioned MCP joint 2 and 3, very good. So osteophyte formation, very good. Asymmetrical joint space loss, very good. Subcondylar cyst, okay. But the bone margin, very good. So Leah mentioned that bone margin is sharp, which is very, very good, okay. Coming to the wrist joint. Sorry, coming to the MCP joint. Second and third MCP joints, reduced joint space, but what is absent? No osteophyte, absolutely great, yes. Okay, moving on to the wrist joint. So there it can be STT joint involvement or first CMC joint involvement or combination. But what is absent? Radiocarpal joint is normal. Okay. Okay, very good. I like your involvement. Very good. So IP joints are involved, interphalangeal joints, and we know that we marginal osteophytosis, asymmetrical joint space loss. Okay, second and third MCP joints are involved with reduced joint space, but no osteophytes. Okay, wrist joints can different combination of first CMC and STT joints are involved, but radiocarpal joint is spared. So if you can remember these things in the hands, you will be safe. You can easily diagnose what is osteoarthritis of the hands. So any question about this osteoarthritis of the hands? Okay. So let's move on to a new next topic, which is related to that. And then if any question, we can take care of, we take that question along with that. Okay. Probably not. Bone density is probably usually maintained unless patient is restricted. So in generally, bone density is maintained. But don't worry about that. DIP joints, bone density is generally normal. Okay. Yeah, bone debris in these X-rays is normal because it's just part of excessive arthritis aging process. Okay, we come to that slack. Okay, thank you. Koram will come to that. Okay, move on to inflammatory arthritis. So I want your understanding why we call it inflammatory arthritis. Name explains that, but why inflammation happens in osteoarthritis? It should be a different category, isn't it? We say inflammatory arthritis or osteoarthritis. Why we call it inflammatory or erosive osteoarthritis? So what's your understanding? Very good. Somebody mentioned infection. Yep. Articular cartilage. I think you more or less you all have some understanding of that. The one who typed there. So let me just cartilage loss. Absolutely right. Okay. So look at this joint. Okay. Synovitis. Yes. So but why synovitis in osteoarthritis? So let me just come to that. So this is a normal joint and this is the joint lining. Okay. So I think you got some understanding. Very good. So this is a cartilage loss. So as there's arthritis, there's asymmetrical cartilage loss. And what will happen that because of this, synovium will get trapped in this area. So there are subcondylosis formation, same thing as we discussed before. So this will lead to trapment of synovium in this part, okay? Because this is not the normal joint now. And that will lead to hypertrophy of synovium and inflammation of the joint. And when there is inflammation of the joint, which is due to synovitis, synovium eats the bone because it's the spinous or synovium which resorbs the bone and produces erosion. So you all know it. It is just because of changed mechanics, because of secondary osteoarthritis or osteoarthritis, secondary inflammation will cause erosions. So this is inflammation because of deranged osteoarthritis. So arthritis comes first, which has deranged and has led to synovial hypertrophy and erosion. Compared to inflammatory arthritis, where the inflammation comes first and eats up the cartilage and leads to secondary osteoarthritis. Okay, so that's a little bit different. So it's just egg and chicken. So in this case, osteoarthritis comes first, leads to synovial thickening. Okay, and it can lead to inflammation of the surrounding soft tissues as well. So very easy to remember, same distribution as that of osteoarthritis. It's the same thing, but when joints become deformed, can lead to inflammation and synovial thickening and erosion. So it is to remember two things for your part 2A, or if you're looking at the X-ray, look at the CMC and STT joints because they are almost always involved, and it is commonly seen in elderly female. It can occur males as well, but commonly seen in females as, more as compared to the males. Okay, so same thing. Marginal osteovytosis in the book says the Gulving sign. I think I would give this thing more importance. Articular surface irregularity is the better sign of erosive osteoarthritis. For your exam, for your 2A or 2B, you can call it Gulving sign. But in real life, it is when the articular surface is irregular, then you call it that there is erosive osteoarthritis. And of course, there can be deviation. We can discuss that in a minute. And of course, because it's a distal thing, it can be due to CPPD and gout. We can discuss that in a minute. Okay. So how we see on plain X-rays. So look at that. This is almost normal osteoarthritis, asymmetrical bone joints space loss, marginal osteophytosis, and maybe some early subcondylosis formation. But look at that. Now, there is significant articular surface irregularity now, okay? And look at the soft tissue swelling around it as compared to this. It means there is inflammation of the joint. Some joints can be a big ossified, but there's no inflammation. But in this case, because of synovial thickening, there's inflammation and there is irregularity of the joint space. When you see this, then you should call it that there is erosive osteoarthritis. Okay, let's have a big view. Okay, you can see that although there is some erosion, maybe subcondylar collapse, but articular surface is sharp. But look at that, it's now irregular and there's a collapse of articular surface. There's no periosteal reaction. Look at the bone margin is sharp. There's no periosteal reaction. Okay, it's the same thing, marginal osteophytosis with central collapse. We can see it here, but articular surface irregularity, bony margin are sharp. Look at the cortex here and see the similar appearance there. There's no loss of margins in the erosive osteoarthritis. And you can have varus or valgus deformity. You can see that there is deformity there, and it's much more on this side. So the finger can deviate on the lateral or the medial side. Look at that, how much subcondylar collapse is there. Although there's no much of inflammation there, maybe a little bit of inflammation there, but this is typical normal osteoarthritis. This may be going into or has gone into previous erosive arthritis because collapse is too much. Look at the margins. Margins are always sharp in erosive osteoarthritis. So very little difference, but only when the articular surface is irregular and there's a soft tissue swelling, only then you call it erosive osteoarthritis. Distribution is same, but look for two things. STT joint arthritis, you can see it here, and also on this side. So a patient can have one of these or both of these, STT or first CMC arthritis, and look at the gender of the patient. Mostly these will be females. I cannot explain why it is more common in females, but it is seen in female. Now look, one more example. There is normal osteoarthritis, maybe subcondylosis formation. Look at here. The joint space is gone on both sides. Looks like there is some infection possibly. But now we look at the previous X-ray about the similar piece, so liver progression, and now it is erosion because pannus or synovial hypertrophy or inflamed synovium has eaten up the bone. Normal osteoarthritis led to synovitis, and that has produced these erosion. Look at the synovial thickening there. Okay. And we did the injection in this patient. You can see that osteophytes there. This is all synovium. This is all thickened synovium. Although it's not acute, acute synovitis because there is no neovascularity, but this is chronic synovial thickening in erosive osteoarthritis. Erosive and proliferative, no, this is not proliferative arthritis. This is entirely different. Okay. Because if you say proliferation, that is, we are different things. So summary of erosive arthritis is it's the same distribution as that of osteoarthritis. DIP joints can involve MCP joints, but same distribution as that of wrist. But main thing is that central collapse or sharp bony margins, and more commonly seen in elderly females. So any question about osteoarthritis or erosive osteoarthritis? Yep. Is there one question? Don't worry, I will show you a summary so many times that you'll be fed up with it. So that will come back again and again. So don't worry. Okay. Synovium is how we differentiate between central collapse from the No, so we'll come back to that. Yeah, you're ahead of time. So we'll come to that, how to differentiate psoriasis from other things. Yeah. Yeah, there's no new bone formation in erosive. That's why I was saying that the margins are very sharp. Look at that, sharp bony margin. If you don't see bony margin sharp, then it may be something else. And we'll come to that. Right, okay. Moving on a little bit. I'm sure I will come to that revision many times, so don't worry about it. Okay. Okay. CPPD. So what is CPPD? Yeah, calcium pyrophosphate deposition disease. Okay, it can be, sometimes it is called as pyrophosphate crystal deposition, or other common name is, it used to be very commonly called as pseudo gout. Okay, it's the same condition, not very commonly called or labeled in subcontinent. Unfortunately, I don't know why, but it is very common actually. Okay, so this is pseudo gout. Okay, same thing as all of you mentioned that calcium pyrophosphate dehydrogenate pyrophosphate deposition disease or pseudo gout. Okay, what is CPPD? So basically, in this case, there is calcification of the cartilage, chondrocalcinosis. This is the main uh, pathophysiology or main lesion in this condition, chondrocalcinosis. Okay, but there can be calcification in the joint, in the synovium, in the ligament, tendon joints, soft tissue. Basically, anything can be calcified, but mainly it's chondrocalcinosis. And second thing is how it presents. What is the radiological presentation of CPPD? Very good. It is osteoarthritis. Very good. Rajat Moore said that it is osteoarthritis, but osteoarthritis at unusual places. That's how we differentiate. It looks like osteoarthritis, unusual places, but associated with large subchondral cysts. We call it geodes. Geode we can see in rheumatoid as well, but large cyst, if you see it, we look for or think of geodes. Okay. So, so what is the distribution? We're not doing the knee joints, we are doing the hands. So what is distribution in hands? Okay, very good. Really couple. Okay. Which MCPQ? Yeah, very good. Which MCPs are mainly involved? Yeah, 2 and 3. Very good. So second and three. So how would you differentiate from osteoarthritis? Osteoarthritis has the same distribution as that of CPPD. Okay. So, and in the wrist, it mainly involves the radiocarpal. I can like it. Everybody is there involved in it. They're very good. So MCP joints, we know that it involves the second and third. In the wrist, it involves the radiocarpal joints. So quite a few of you have mentioned that. What is the difference? So let's come back to what happened in CPPD. There is a calcification there. Okay. You can see that the TFC calcification. There can be calcification of the cartilage between the lunate and tricutal bone. There looks like chondrocalcinosis here, and looks like there's a calcification of the scapholunate ligament as well. Okay, here you can see that TFC calcified. Quite a few of you mentioned it, and you can see there's calcification of lunotricutal ligament. Okay, so it can basically involve the cartilage, whether this is the hyaline cartilage, which is a joint cartilage. It can involve the fibrocartilage, which is TFC, but it can also involve the ligament, soft tissue, synovium, anything you can involve. But cartilage is the main thing. Now, starting with the wrist joint, remember this appearance. Radiocarpal joint isolated involvement is very typical of osteoarthritis, sorry, CPPD. As I mentioned that in osteoarthritis, STT and first CMC is involved, but radiocarpal is generally spared. That's what we mentioned, that it's a negative. But if you see that, especially when you can see that it's a caving in appearance of the distal radius, it is very typical of CPPD. You can see that. Bilateral symmetrical. Can be asymmetrical, of course. And when you see that, look for any calcification. You may not see calcification always, okay? But you see this appearance of the radiocarpal joint involvement. Think of CPPD. Let's move on. Okay, so what happened when there is, go back, when there's a involvement there is some microcalcification in the scapholunate ligament as well. So because of this joint involvement, arthritis, some more pressure in this ligament, scapholunate ligament, and there is usually tear and widening of the space. And this will sink down or sublux proximally, and that's we call it slack. I'll show you in a second. Okay, so you can see that there's a calcification there, significant osteoarthritis, both sides, scapholunate gap is increased. So what will happen? Capitate will sublux proximally, and it will cause arthritis now because normal alignment is gone. So this will lead to secondary osteoarthritis, and this is called that scapholunate advanced collapse or SLAC. Okay, so somebody asked what is SLAC? Here's your answer. When this is torn, scaphoid or lunate, they move apart, capitate will move in, and because of this abnormal alignment or abnormal articulation, there will be degenerative changes in this area, and this is called as scapholunate advanced collapse. Another example, look at that, radioscaphoid, loss of joint space, subcondylar sclerosis, gap is increased in the scapholunate, and significant osteoarthritis because capitate has sublux proximally, and there is osteoarthritis between the lunate and capitate, or can be anything. So there's arthritis in the mid-carpal joint. So this is SLAC. Whole picture is that of CPPD in the wrist joint. Okay, so isolated radiocarpal osteoarthritis is typical. It can involve other parts of the joint, but this is very typical. Calcification of the ligaments. Can see the calcification here. So this is ulnar collateral ligament of the wrist joint that is involved. And we can see that the scapholunate gap is increased. And secondary osteoarthritis, because of proximal migration of the capitate, we call it SLAC or scapholunate advanced collapse. Okay, another example. So what do you think happening here? This patient was sent to us from a DGH because we are bone center at that time. So they asked, is this giant cell tumor? Patient was in 60s. Do you think it can be a giant cell tumor? Yeah, very good. Because we are discussing CPPD, so this is probably large geode. Okay, sorry. So you can see that there's arthritis in the rest of the joint, but radiocarpal is still I'm not saying so. It's radioscaphoid is typically involved. Joint space is increased, but no significant migration. But this is a large geode here in the, and yeah, a little bit slack as well, but a large geode in the distal radius. And we did MR scan. I think it was done in the periphery somewhere, and you can see that it's very typical appearance. No fluid or fluid levels to suggest this is giant cell tumor. So going back, we don't need MR scan to do that. I think it was done because it's not just a giant cell tumor. So this is a very typical appearance. You don't need to see calcification all the time, but if you see this appearance, think of CPPD. Somebody will come back. Don't worry about that, Gajan. It is coming. Okay. Now moving on to metacarpals. So we said that it can involve second and third joints, just like osteoarthritis. But look at that. What is this? Calcification in all the MCP joints. As I said, we usually do not see calcification in the osteoarthritis. And most importantly, we see hook osteophytes, okay, on the radial side, okay? And there we go. Joint space is reduced, osteoarthritis on both sides, and we can see that they are hook osteophytes. So in osteoarthritis, we said second and third MCP joints can be involved without any osteophytes. So when you see osteophytes, think of CPPD. Okay, you can see that osteophytes. There's osteophyte there, there's osteophyte there. And what else we said in the osteoarthritis? STT and first CMC joint can be involved, but radius scaphoid is spared. So radius scaphoid is involved in CPPD. So there are two signs you learned, you exclude, you can easily separate it from osteoarthritis. Okay, another example. But now we can see that these are osteophyte in fourth and fifth joint as well. So what is this? It is still CPPD or something else? Very good, Vishnu. So how does hemochromatosis does? How does hemochromatosis can lead to disappearance? It is right. So when we see this appearance, when joint space is reduced in all the MCP joints, but there is prominent osteophytes, radial side osteophytes. But when you see the fourth and fifth are involved, think of hemochromatosis because hemochromatosis leads to secondary CPPD. There is a chemical mechanism where it affects the enzyme function. So this is secondary CPPD due to hemochromatosis. But you can differentiate it when you can see these things, similar appearance of second and third in fourth and fifth, you can call it hemochromatosis. The very simple differentiation. Similar picture in fourth and fifth is hemochromatosis leading to secondary CPPD. Okay, so have a look at this one. You can see that there is reduced radioscaphoid distance and no calcification. Can't see any, little bit of widening of scapholunate distance, but no calcification at all. So it is just osteoarthritis, no signs elsewhere. So what do you think? How would you confirm? How do you go about it? Patient are wrist pain. We just call it osteoarthritis or CPPD, although treatment is not much of different. But rheumatologist wants to know whether this is something else or this. Yeah, maybe some slack, but not much. So question is this CPPD or yeah, you can do elbow, very good. But where is the biggest cartilage in the body? Thickest cartilage? Knee, absolutely. Hip probably not, knee is probably the best, okay? So we looked at the previous imaging and this is the previous imaging. Can you see any calcification? Can see these calcification? Yeah, calcification there. Faint calcification in the cartilage as well. Very faint, but definitely posterior meniscus is calcified, which is a fibrocartilage. Maybe some calcification in the synovium, okay? So I know it's maybe sometimes it doesn't project very well, but I'm sure you can see some calcification there. So you can look around somewhere and you can confirm that there's a calcification in the body. You don't have to do anything, just confirm that this is CPPD. So this is a summary. Who was asking for the summary? So this is a summary for CPPD. Calcification phenomena, we know that there's a calcification of the, predominantly calcification of the cartilage, but it can occur in the tendons, ligament, and synovium or other soft tissues. Okay, we can see involvement of second and third MCP joints with osteophytes. And radiocarpal joint, we can see involvement, isolated involvement, along with slack. Okay, and if all MCP joints are involved with hooks, think of hemochromatosis, which can lead to secondary pyrophosphate dehydrogenase disease. So any questions so far? So far, with a couple of hints, you can differentiate osteoarthritis from CPPD and other conditions. Did you have chondrocalcinosis? I'm sure you can look into the Chapman. There's a big list of that, but mainly it's calcium deposition diseases which can do it. But we're not doing the differential. We just how to differentiate these conditions, which are the common conditions. So no question. I'll give you a few more seconds. Okay. Okay. This is another teaser for you. This patient presented with severe wrist pain. Okay, one-sided. Okay. So what is this? Patient won't let you touch it. Yeah, very good. Infection possibility because there is osteopenia. Septic, very good. Can be infection, can be rheumatoid. Sympathetic, well, yeah, can be. Yeah. One thing I think you all mentioned right, but you did not mention one thing, which is this is actually. You know what we call, what is the name, other name of gout? In MDTs they call it. No, it's called as master masquerader. It is so difficult to differentiate from other conditions that it can mimic some other condition. Let's go back. Okay, all the differences you mentioned is correct. I mean, I would call it rheumatoid arthritis. I would call it septic arthritis because there's soft tissue swelling, erosions, osteopenia. Everything fits in both conditions. But we forget about gout because it is such a mimicker that it can basically toss you up sometime. It can throw you up, and you always think, oh, what is this? And then sometimes you hold your head. Why didn't I think of that earlier? So this was a case that one of those cases which we struggled, and in the end, of course, we reach it. But there's one clue we did not think that time. We'll come back to that in a minute. Okay, gout. We all know that it is crystal arthropathy. So it is not inflammatory arthropathy. It is crystal arthropathy. Okay, because of MSU, monosodium urate crystal deposition, and in the blood there's a high uric acid level, and that leads to deposition of these crystals in the synovium, soft tissues, and bone. So wherever this deposition is, it will lead to inflammation and reactive changes in the soft tissues and the bone, of course, erosion. No, we cannot. There's a question there with the normal uric acid, can we rule out gout? No, I don't think so. It has to be a clinical, but serum uric acid can be normal, but patient can have symptoms. Right. It's very simple. You have seen once you know it, it's very easy. Big. So any part of the hand can be involved. Okay. And erosion can occur anywhere. Okay. And can also involve the DIP joints. There's a reason for that. I'm mentioning that. We'll come back to that later. Okay. Erosion can occur anywhere in the hands, and they can also involve the DIP joint, and it is or can be associated with asymmetrical soft tissue masses like we see it here. They're never symmetrical. They are more dense on always on one side, even if it looks symmetrical, but it's more dense on one side as compared to the other side. Okay, so any joint can be involved. There's erosion of the DIP joints, can be erosion of DIP joints, and asymmetrical soft tissue masses, which are very dense. We all know about the erosions. They are extra-articular, overhanging, shelf-like, mushed out like rat bites. Usually bone density is maintained. But when they are quite big, they can also extend to the articular surface when it make it slightly difficult to differentiate from the rheumatoid arthritis. Then we have to look for other clues how to differentiate between these conditions. Okay, so look at that. Let me just make it big actually. Okay, so large erosions in the DIP joints. Okay, look at that. It is extending into the joints. Here it is extending into the joint, but look at that, very sharp margins. Look at the whole finger is swollen. Look at that, a big joint erosion. Same thing, but bone density is still maintained. Okay, and that's very typical of gout. So erosion can be overhanging, sharp margins, normal bone density. It can, but important thing is that if it is in the DIP joints, large erosions in rheumatoid are not very common. So if you think something is there in the DIP joint, you can easily rule out rheumatoid arthritis. No, it doesn't look like psoriatic arthritis. We'll come to that and then we'll differentiate from that. Okay. Somebody asked a question about that. So think of this, but again, look at the bone margins. Are they sharp or not? Very sharp bone margin, very sharp bone margin. Density is maintained, soft tissue swelling, asymmetrical densities, more here, more around these areas. So very typical of gout. Remember, thing to remember here is large erosion in the DIP joint exclude rheumatoid arthritis. Septic arthritis will lead to low reduced bone density. Their bone density is maintained and they do not give sharp margins. They have a blurred margins. Okay, another one can see that although quite a big erosion, asymmetrical, more prominent of soft tissue on this side, very dense, but erosions there extending to the joint. And so what can be the differential? So we have ruled out rheumatoid arthritis. So what else can you consider in the differential now? Gout is one. Sarcoid, yes. Septic possibility with the bone density like that. Let's stay on the things we mentioned before. Let's stay on the common things. Psoriasis, very good. Psoriasis or seronegative arthritis is a disease of distal joints. Erosive arthritis, very good. Very good. So we have two differentials apart from gout, or in fact, if you include gout, three differential. If you see erosion in the DIP joints, think of erosive arthritis, seronegative arthritis, and gout. Of course, in this case, we see the well-defined erosion, bone density is maintained, sharp margins, asymmetrical soft tissue masses. This is most likely gout. Okay. Now, this is the, remember that in the wrist, gout can involve the whole wrist. Okay. But look for the erosions in the distal part of the joint or metacarpal basis. Involvement is very typical of gout. Okay. So if you call it that, if there is a little bit of osteopenia in this image, I would call it, it looks like rheumatoid because there are erosions, secondary degenerative changes, but erosions in this metacarpal basis are very typical of gout rather than rheumatoid arthritis. The big erosion of the metacarpal basis, and same goes for the foot, metatarsal basis is typical of gout. So remember, absorb this. So I'll show you that X-ray we saw before, and that clue was there. So as I said, we need to have a bit more osteopenia with this much of erosive change in rheumatoid arthritis. So this was the X-ray I showed you. We missed this. We did not see at that point. So we were sitting there next 1 week, we call it that this is probably septic arthritis. We aspirated, nothing came out. We didn't do the crystal. We were suspecting infection because it presents acute gout is very, very painful and very swollen and very inflamed. So patient wasn't very happy. We did the aspiration. But when we tried, next day we have a very senior colleague who said, oh yeah, it looks like there is erosion there. And this is most likely gout. And then, well, yeah, this is gout. We already knew it is gout, but we didn't think of that. Geode is, there's no calcification. There's no other sign of geode. Geode is usually in the big bones, not in the small bone. Can happen, but there are no other signs of calcification. I'm not sure Momal asked something, but I'm not sure what she wants me to explain. Momal can just type here. So here you can see that there's marked osteopenia because of chronic gout. Now it's been there for some time. There's erosion there. Okay, I go back to last slide in a minute. Okay, and you can see that there is a big erosion in the metacarpal base. And this is the MR scan, maybe sometime after or before, I don't remember. But you can see that proximal part of the joint is preserved a little bit as compared to distal. There's a lot of inflammation, and that's where the erosion was in the second metacarpal base. Okay, I think, let me go back. I'm not sure what we didn't understand. Let me just click on it. Oops, sorry. So in this slide, I want to say that in gout, that can involve any part. There can be erosion anywhere. But if you see big erosion on the metacarpal basis, think of gout. That is very common in gout, usually not in rheumatoid arthritis. But if this is another clue is that if this is rheumatoid arthritis with that much of erosive change, we would have expected a bit more osteopenia, because you can't have that good bone density in rheumatoid with that much of erosion. So that was my point in here. But remember this thing. When there is involvement of the wrist joint and you see erosion of the metacarpal basis, this is most likely gout. Okay, so this is, as mentioned, this is my initial case I showed you. This was a clue here. Of course, there are many erosion there, another erosion in the distal radius, and erosion of the tricutal bone, marked osteopenia. It can be septic arthritis, it can be inflammatory, but this is a clue. Big erosion of the metacarpal. Okay, another case. Eccentric erosion, also in radial involvement of the scaphoid, and there is a dense soft tissue mass. Okay, so this is, again, of course, we can see calcification of the cartilage in gout as well. Gout also outlines ligaments, can also outline cartilage. So we know that. So in the foot, what is the commonest place? We all know that. Big foot. Okay, and other thing I mentioned there, TMT joints. So forget about TMT joints. We all know about first MTP joint or big toe joints, but it also involves the TMT joints. And the rule is same. If you see big erosion of the TMT joints, think of gout. Look at that. This is very typical. You can see that big erosion, extra-articular erosion, dense asymmetrical soft tissue mass. Okay, and the big erosion can, in fact, erosion here, big soft tissue mass, tophaceous gout, and same thing is here. Okay, you can see another case, typical location, first IP joint, big toe, but erosion is extra-articular soft tissue swelling, maybe early erosion there. Okay, and we did MR scan. I don't know why we did MR scan, but it was done. I don't remember now. You can see that. So to look, you do not do MR scan to diagnose gout because you'll be more confused. Always look at the plain X-ray or ultrasound. Okay, so because you'll get more confused. But this was done due to some reason. So look at the bony margins. So we'll go back. Okay, this is the erosion there. Let's see the erosion. So this is a normal cortex. We're seeing, and we start losing that cortex. This whole thing is erosion. This all is gouty tophus. You can see that there is early erosion. You can see the gouty tophi here, and it's starting to eat bone here. And that's how it looks on the T2. Early erosion, this is crystal deposition, and we started to see a bit more deposition on that side. But I do not want you to use MR scan because I find it very difficult. We tend not to do it. Okay. So same thing as before. Look at the TMT joints. If you see something, always think of gout, just like CMC joints, especially when there's erosion of the metatarsal basis. So two things we remember in gout. In the wrist, look for the metacarpal basis. In the midfoot, look at the metatarsal basis. And involvement of midfoot joints is not uncommon. It is in fact quite commonly missed. because people don't know what it is. So if you start looking for it, I'm sure you can email me that I started seeing it. You're very good. Somebody asked me, Charcot's osteopathy. Yeah, very good. Charcot's can give this appearance, but Charcot's doesn't give erosion. There's a destruction and debris, and bone density can be maintained or increased, and alignment is wrong. It doesn't lead to alignment loss generally, and patient is usually inflamed as compared to neuropathic arthropathy, where patient is painless, doesn't feel any pain. Very good question though. So this is a case. Anybody have a look at it? I can tell you midfoot gout, but what else? We can see that there's erosion there, but what else is going on? Yeah, where is the tophaceous urate deposition? Very good. Plantar fascia is probably okay. I think we didn't cover it, but yeah, this is gouty tophi. It is seen on the external surfaces, on the back of Achilles tendon, olecranon fossa on the back of elbow joint. Very commonly seen. Okay, if you start looking, you will start seeing that. Okay, even on the, I didn't have plain X-ray of this patient. You can see the plain X-ray as well. So when you see these erosion, it can occur in rheumatoid as well, but not very common in this area. Somebody mentioned that, very good question, that midfoot arthritis, we can have erosions in the seronegative other, but I think there's edema is more common as compared to erosions on MR scan in Charcot's or neuropathic arthropathy. Very good question. Okay. So in this case, we have erosions of the TMT joints, and there is Achilles gouty tophi. So this is a summary of the gout. Any joint can be involved in the hands, but if you see the DIP joints with the soft tissue swelling, it is most likely, or asymmetrical swelling, it can be gout, okay, because it can involve the DIP joints. We know about the erosion. They are punched out erosion, rat bite, extra-articular, asymmetrical soft tissue masses, very dense. Wrist pen compartment, but CMC joint with a large erosion is typical, especially the metacarpal basis. And same as the foot. Big toe involvement or big toe or any small joint can be involved, but the big toe and IP joint of the big toe and MTP and IP joints and TMT joints. But if you see any big erosion in the metatarsal basis, think of gout. So any questions so far? Yeah, it's a very good question. Ramika asked this question. Bone density in acute gout is preserved, but when it's a chronic gout, because patients start to have disuse, then bone density is reduced. So in acute gout, it is preserved. So any question about? Okay, I think we got more than an hour. Let's get the question here. Okay. Which thing we're talking about? Joint space, JK? No, not really. These ones, because it is destroyed by, it's not narrowed. It is destroyed by the gouty tophi. There's not, there's no matter of preserved because it's been eaten up by the crystals. Okay. Uh, Gout can occur in there, but you should have more destruction in Charcot's arthropathy. Question is what is the DD of gout with Charcot's? How to differentiate? There is more debris, more disorganization of the foot in Charcot's, and just ask the history. A patient will have no pain. It's very important. Yeah, somebody said DDDDs. Okay. Right. Should we get 5 minutes break? and we come back and then start with the revision and move on to the next topic.
Right. So now will be a 5-minute break, and we'll start after 5 minutes. Thank you.
Okay, should we continue with the topic? Okay, let me just go back to where we left. Yeah, the couple of questions in the meantime. Uh, it can gout involve at lentoaxial joint? Not commonly. It's a pseudo-gout. It's CPPD, which is a crown dense appearance, which is a different topic. So just concentrating on this one. Somebody said, what is your favorite MR sequence for gout? There's no favorite sequence for MR scan for gout for me at all. I tend not to do gout, MR for gout because it just confuses you more. Okay. Okay. So you can say why these cases are sometimes because we are tertiary center. These we get these cases from periphery and we look at it when everything has been done. So generally, we hardly do any. If we know that's gout, we'd never do MR sequence, MR at all. Okay. Right. Okay. Let's go back. Let's recap before we move forward. So we should know what is going on. So I just want you to participate. So what we decided about the osteoarthritis of the hands? What is the summary? Yeah. Distribution. Very good. Very good. Absolutely. I think the most important thing is that the negatives, because we know about the other things. So important thing to remember is that the negative. Very good. So let's start. IP joints are involved, distal or proximal interphalangeal joints. And we have second and third MCP joints involvement, but without any osteophytes. And the wrist, we can know that radiocarpal joint is preserved. And we have STT and first CMC joint involvement in the wrist joint. Okay, very good. What is erosive osteoarthritis summary? What is the involvement? Very good. Same as osteoarthritis, as simple as that. Okay. So how would you differentiate from osteoarthritis then? What happens when we call it osteoarthritis going into erosive change? Very good. You got the gist of articular surface collapse and soft tissue swelling is the main sign. You can give Gulbing sign if you're in the exam, but that is my opinion is probably not the case. Very good. Articular surface irregularity and soft tissue swelling. And commonly seen in which group? Elderly females. Okay. Yeah, very good. And we should also look for, if you're looking at the X-ray of the hand, you see the erosive change. You should look for wrist. What part of the wrist joint? STT joint and first CMC joint. Okay, same thing as osteoarthritis because I come back to that in a minute because in certain other conditions, DIP joints can be involved, but it is not erosive osteoarthritis. And in that case, SCT and first CMC joint may be normal. Okay, very good. Okay, same as OA, marginal osteophytosis, but and main thing I think I forgot to mention that the sharp bony margins. There is no fluffiness of the periosteum. The sharp bony margins. SCT and first CMC joint osteoarthritis, and is commonly seen in elderly females. Very good. CPPD. What is the distribution in the wrist and in the MCP joints? Very good. So now we see arthritis in the second and third, but with osteophyte, hook-like osteophyte on the radial aspect. Very good. Excellent. Okay, and we see if third and fourth joints are involved, third and fourth MCP joint involvement, and that it is hemochromatosis. Okay, very good. And in the wrist joint, Yeah, radiocarpal joint. So we said two negative things in osteoarthritis, that there's no osteophyte in the MCP joints and radiocarpal joint is normal. And because these things are positive in the CPPD, so these are main differentiating point. Very good. Gajan said that there is chondrocalcinosis, which is the main hallmark, and we can see calcification somewhere. Okay. Calcification of the cartilage, tendon and ligament, but cartilage is the main thing. You all mentioned that second and third MCP joint osteophytes, radiocarpal joint osteoarthritis, and if all MCP joints are involved with osteophytes, think of hemochromatosis because that can lead to secondary CPPD. Excellent. Gout. So, what is involved in the hands? Which joint? Any joint can be involved. Very good. What is the main thing? If you see involvement of DIP joints with soft tissue masses, gout is a possibility, isn't it? Very good. Soft tissue masses, densities, punched out erosions, very good. Okay, what about the wrist? Yeah, metacarpal, big erosion in the metacarpal bases is typical of gout. And same thing is the metatarsal. Big erosion of the metacarpal bases and metatarsal bases. Think of gout. Okay. Any joint can be involved. Typical erosions, asymmetrical soft tissue masses, pan compartment, but CMC jointed with large erosion. Same thing as the TMT joints. Excellent. So we've done most of our, uh, in fact, half of our work in arthritis. So if you can remember these 4 slides, I think we have done most of the work. So if we can, the rest is not that difficult. So rheumatoid arthritis. So what is the main pathology in rheumatoid arthritis? Yes, it's inflammation of the synovium. That is the starting point. Okay, so there is synovium which gets inflamed and it eats up the bone, and that can lead to changes in the cartilage. Wilkes, everybody's saying is the right thing. Okay, pannus formation or inflamed synovium. So this is a joint. So there's inflammation of the joint. There can be inflammation of the soft tissue. Swelling in the early part of osteoarthritis is not in the joint, it's usually outside the joint. Okay, but can happen. So you can see that there is inflammation of the synovium, which extends to the bare area. Bare area is the area between the joint capsule and the cartilage, because synovium can attack the bone directly, because the rest of the things are resistant to the synovial uh, reactive change. So synovium can eat up the bone in this bare area. But once it gets hold of things, it starts getting extends and involve the cartilage. Okay, so it eats up from there. Erosion starts at the margins, and it can eat the more bone and leads to involvement of the cartilage, loss of joint space, and subcondylosis, and in the end, it can be joint fusion. That is the normal progression of rheumatoid arthritis. So this is called a secondary osteoarthritis when we see degenerative changes following inflammation. So which part of the hand is involved? Yeah, MCP, PIP. Basically, if you want to phrase it in one way, proximal part of the hand is involved. Okay, can be MCP and PIP joints. They are mainly involved. Okay, so mainly MCP joint, but PIP can be involved. Okay, I don't remember that, because just remember that proximal part of the joint. Important things that erosion, as we said before, DIP joints are usually not involved, or if it's involved, there aren't big erosions in rheumatoid arthritis. Very good. So, as we said before, look for the erosion on the radial aspect, because erosions in the MCP joints are quite common in rheumatoid arthritis. So if you're looking at the wrong side, then you may misinterpret. So always look on the radial side. So maybe some erosion there, looks like there. Maybe not sure about this because this can be normal, we know that, so I'm not sure. So what you do is always look at the radial side now. You can see there's a erosion on the radial side, maybe on the side, but we don't know. But big erosion in the second metacarpal head. There's a small early erosion in the proximal phalanx space. So rule is always look on the radial aspect. Okay. Erosions are, as I said, periarticular in the bare area, but we can start anywhere. So if the joint capsule inserts there, you can see that this is the erosion. Okay. It is not really well defined, unlike gout. This is a very, when you starts as a very fluffy or very ill-defined type of erosion. And there's another erosion at the base of proximal phalanx. Okay, again, margins are not very sharp. So fully defined periarticular erosions, no new bone formation. Look at the margins of the bone. They are sharp, no periosteal reaction. Okay, you can see that very fine margins here. Nothing is abnormal there. Okay, let's see another case. So can you see any erosion? This is early erosion of osteoarthritis. Okay, so osteoarthritis, sorry, rheumatoid arthritis, and possibly early erosion of the base of proximal phalanx. But margins are sharp, no periosteal. Look at how crisp, sharp margins are there. So make a habit of magnifying your images as much as possible. I'm sure you all have now monitors, but if you don't, if you're still doing the old style, all magnified or use the magnifying glass to see the margins. Okay. So erosions are periarticular and no periosteal reaction. Of course, this is easy. Big erosions, central erosions, but look at that. Margins are still sharp. No fluffiness. This is very typical of rheumatoid arthritis. Okay. So generally, when we see patients with rheumatoid arthritis, we see periartical osteopenia. If you look clearly, look at that. How much is the low density around the joints? Okay, these are fine in the middle, but the periartical osteopenia here, not much in the DIP, sorry, PIP and DIP joints, just mainly centered in the wrist joint and around the MCP joints. And you can see that there are multiple erosions, and there are erosions in the wrist joint as well, especially on the ulnar side. There's also erosion of the, yeah, somebody mentioned very nicely that the erosion of the ulnar styloid process. So these are things, osteopenia, soft tissue swelling. You can see that there is a soft tissue swelling here and periarticular erosion. This is, we all know about, done the stuff. Another case, same thing there, multiple established erosions. Not much soft tissue because they are not very acute, but can happen. And you can see that there is some secondary degenerative changes and subluxation there. So what happens here? Sorry. I'm not sure what I have to say. Same thing as in the magnified view of the previous image. Okay, where is the inflammation in the wrist joint commonly? It can involve any part of the wrist joint, but mainly on the ulnar side. That's where it starts. It can involve, just like gout, all wrist can be involved, but mainly on the ulnar side of the wrist. Okay, like styloid process, tricutril pacciform bone. Okay, why it is more common on this side? Yeah, somebody JK said it's some because of tendon. Which tendon is there? ECU, very good. What else? You think one tendon will do everything? You're right. But yeah, somebody said, Venkatesh said there is synovium in this region, and that is probably the right answer. Okay, let me just go back. Okay, so look at these two x-rays. Maybe some erosion there, not sure, but look at that, the erosion here of the tricutril bone. Another erosion on this is opposite side of the same patient. Okay, and again, erosion on the ulnar side. There's erosion of the styloid process, big erosion. This side, not eroded, looks like chronic erosion there, but of course the patient has other erosions as well. So this is established erosive change in the MCP joint and the wrist joint. Again, same thing, magnified view, prominent erosions. So we do ultrasound, that's how you see erosion. You can see the normal outline of the bone here, and this is the defect on the top. However, there's a normal pit on the top as well, but this is not smooth. That is smooth, okay, at the head and neck junction, but this is irregular because you can see the synovium is going into it, and there is some vascularity as well. And this is on the ulnar side of the wrist joint. You can see that there is synovial thickening with marked vascularity, which means it's active synovitis. Okay, something is there. All so you can see that this part is all very active as compared to the radial side. You can see some inflammation there, but this is much more inflamed as compared to the rest, because you can see that this has led to erosion of the triquetral bone, erosion of the ulna as well. The styloid process we do not see because this area is surrounded by synovium. Okay, you can just below the TFC there is a gap, and that is filled with synovium. And just between where this gap between the styloid process and trochlear bone, there is more synovium, meniscus homologous we call it. This is also synovium around it, and of course, you guys said there is ECU tendon, extensor carpi ulnaris tendon, around it as well. Flexor carpi ulnaris as well on the other side, but mainly ECU tendon. So the whole area is surrounded by inflammation, and due to some reason, this area is uh, more like by the rheumatoid arthritis. When it is inflamed, it can lead to erosion of the bone, styloid process, and erosion of the triquetral bone. So if you're looking for the X-ray and the question mark is, are there any erosions in the hands? Look at this area very, very closely, and you may find early erosion. And same thing when we do scanning, ultrasound scan for early erosions, and we look for this area to start with. That's where we find early erosive change. Okay, this is like, look at the example here. Rest of the bones are fine. Look at that. Quite irregular appearance of the ulnar styloid process, bit of osteopenia, soft tissue swelling, typical of early osteoarthritis. No, sorry, early rheumatoid arthritis. Another case, look at that. This area is fine. There's some erosion. Soft tissue swelling is there. Can you see that soft tissue swelling? Erosion of the triquetral bone, maybe early fusion of the scaphoid and lunate. Let's come on this side. There's erosion there. And look at that. Styloid process. Significantly eroded. There's erosion there as well. Soft tissue swelling around it. Early erosive change. CPPD doesn't involve this area generally. Okay. Okay. For this case, look at that. There is soft tissue swelling on X-ray, but styloid process is perhaps normal. It doesn't look that bad. Soft tissue swelling is there. We did the ultrasound. There is significant synovial change. And you can see that there is significant synovitis around the styloid process. There's an early inflammation, and this is early presentation of the rheumatoid arthritis. So if you're looking for any X-ray for rheumatoid, start there. And chances are you may find some erosions there. You can look at the MCP joint and other PIP joints later on, but that's the area you need to concentrate. Maggot, make sure that you look at that very closely and clearly, and not only the bone, but also soft tissues, and also the osteopenia. Look at this X-ray. Rest of everything is fine. This area is eroded, and there is surrounding soft tissue swelling as well. Little bit of osteopenia, focal osteopenia around the distal ulna. Okay. Of course, complication is very easy. We can see that there is a fusion of the carpal bones, and there is, of course, a bottom-nail deformity, flexion at PIP and extension at DIP, and if the reverses, it's called swan neck deformity. Anybody knows it. You don't need any radiologist to report that. Okay. Foot. So what is the involvement of rheumatoid arthritis in feet? What is the distribution? Very good. Gooden said fifth metatarsal head. What is important? Yeah, I agree with that, but what is the importance of that? Yeah, erosion. Early erosions start from the fifth metatarsal head. Okay, so if you looking for the early erosions, like on the hand, your wrist, you're looking for the ulnar side. In the foot, look at the fifth metatarsal, and that's where the early erosions are seen, commonly seen. Okay. In the foot, it's the same thing. It's a proximal part of the foot is mainly involved, MTP joints, but can involve the PIP joints, mainly MTP joints or IP joint of the big toe. Okay. Fifth metatarsal base, it shouldn't be base, sorry, it head can be the least erosion. Sorry, the typing error. So it's the fifth metatarsal head where you should look for earliest of erosion. Okay, and it, of course, DIP joint, just like hands, is usually spared. Okay, can you see any abnormality? So if you're looking for metacarpal head, always, unlike hands, look for the medial aspect or inner aspect of the metatarsal heads. But in the fifth MTP, it can occur on both sides. That's the main thing. But anyway, you can look at on any X-ray, just try to find erosion there. But that's the area you need to concentrate. Head of fifth metatarsal, where the early erosion start. Okay, you can see that erosion there. Big soft tissue mass. Now erosion is both bilateral here, and there's erosion involving the base as well. Look at the soft tissue swelling around. Significant soft tissue swelling because it's the quite inflammatory condition. Okay, same thing. Erosion on both sides there, and soft tissue mass and osteopenia as well. So can we see erosions at the tendon insertions in rheumatoid? Can occur, but it's not the hallmark of it. It is the hallmark of seronegative arthropathy. But why would then we see erosion there? This is a rheumatoid patient, erosion there. Very good. Retrocalcaneal bursa. JK is very good. Because this area has a retrocalcaneal bursa, which is a synovial thing. And the main involvement of rheumatoid is synovitis. It picks up anything which has synovitis. So Achilles tendon doesn't have synovial sheath. So Achilles tendon will not cause inflammation, but it will cause inflammation secondary to this inflammation of the retrocalcaneal bursa. But if any tendons in the hands we see rheumatoid patients, because these tendons have synovial sheath, the patient will have tenosynovitis. So now main thing is that erosion of the rheumatoid have, especially in the big areas, have sharp margins, and there is no they can have well-defined margins, but no periosteoreaction. That's how I should phrase it. No periosteoreactions, no fluffy periosteoreaction. That is the most important thing to differentiate. So rheumatoid summary, bilaterally symmetrical. I don't think so it's symmetrical anymore because we are doing imaging much early. So it is bilateral, but maybe asymmetrical. We don't worry. I mean, in the book still says symmetrical. It's not symmetrical nowadays. Periarticular osteopenia, we all know that, nothing special. We know that it's a disease of proximal part of the hands. And wrist, it's a pen compartment, can involve anything, but mainly starts on the ulnar side. And in the feet, it can involve MTP joints, but starts on the fifth metatarsal head. That's where you need to look at. And periarticular erosions are not associated with any periosteoreaction. So how it is going? Any questions so far? Okay. I give you a few more seconds before you have a question because we are moving on to the last bit. I know we're all getting tired. I'm getting tired, but hopefully we'll be done very soon. But hopefully once we get all of it, we have a little bit more understanding how to approach these. We don't have to remember too many things, just important positives and few negatives, and then we can reach diagnosis. Geode, yes, it's the same thing, it's subcondylosis, but yeah, usually not that big. Can happen, but not that big. Sorry, your questions are coming very fast. Yeah. Yeah, rheumatoid erosions are ill-defined, as I mentioned. Gout erosions are very, yeah, somebody was saying. Yeah, gout erosions are very well defined, punched out erosion. And In osteopenia, rheumatoid can, if it's marked osteopenia, it can difficult. So if patient is very osteopenic, erosions are quite difficult to see. Yeah, I mean, rheumatoid is, I don't think it's symmetrical all the time. It's asymmetrical because we are doing imaging much more early now. Previously, patient never used to come to the reach the imaging, sorry, X-ray department for imaging. So, but most of these patients are asymmetrical, even in rheumatoid arthritis. So that's the old saying. Right, moving on to the next bit. So, but most important before that, what is antithesis? Most important, what is your understanding of thesis? Antithesis. I'm sure some of you might know what is antithesis. I'm missing the messages, sorry. Tendon involvement, insertion point, very good. Swelling, ligamentous insertion, yeah, more or less, sorry, yeah. Antithesis is the normal thing. Enthesopathy is the inflammation of tendon attachment. Okay, yeah, I think more or less you have some understanding. Okay, yeah, let me just come back to it. Very good. Okay, so antithesis is, what happened? So this is the, anything which attaches to the bone attaches with the fibrocartilage between the bone and the structure. So suppose this is Achilles tendon, this is calcaneum, and Achilles tendon will insert with the help of fibrocartilage. And this combination or this complex is called antithesis. It can be tendon, it can be ligament, it can be joint capsule. Anything which attaches with the bone is never attaches directly. It attaches with the fibrocartilage. This is a normal antithesis. Okay. So what happens compared to rheumatoid arthritis? Seronegative arthritis is disease of antithesis primarily. So if you're looking at the joint in psoriasis, we are looking at the wrong place. You need to look at the antithesis where the tendon, joint capsule, or the ligament attach. So that is the area you need to look where the joint capsule or tendon is or ligament is attaching there. So it can lead to erosion at this area, this inflammation where antithesis is there, and that will lead to erosion in this area. And sometimes there can be secondary inflammation and some changes of inflammatory arthritis. But main problem always is here at the antithesis. Okay, so just see this joint. Okay, so this is the joint capsule attaching to the bone, and it gets inflamed. It will produce erosion, but this erosion is usually because it's not the synovium, it's just the inflammation of the antithesis. There is a reactive bone formation, and that can lead to fluffy outline of the bone. Okay. Then secondary changes in the joint lead to inflammation or inflammation of the synovium or synovitis, and then leads to inflammation, and that eats up the cartilage, just like other inflammatory arthropathy like rheumatoid arthritis. So process is startup entirely different. Okay, so this is the attachment of the tendon to the bone, and it is outside the joint. So it can still have enthesial edema, okay, and it is outside the joint, and that can lead to erosion there, and then can lead to fluffy periosteal reaction. Okay, same thing with that. So when there's inflammation, then can lead to new bone formation. But this is not enthesial abnormality. This is just like graying of hairs. We get old, we start having gray hairs, okay? And this is a normal bone extending along the antithesis, okay? Because it has a sharp margin, okay? And it is because of traction. We use our feet all the time or in the area with the traction. This may be a runner in the youth, and some people are just more prone to it. They have more anthesial bone formation, but this is not inflammation. This is just fraction leading to the new bone formation because outline is sharp. This is still normal. But what happened in seronegative arthropathy? So this is we mentioned that a rheumatoid patient, because of retrocalcaneal bursitis, there is erosion. But look at the bone margin. It's very sharp. Okay, bone margin is very sharp. Now look at here. There is erosion, but now there is a fluffy periosteal reaction because there is tendon, Achilles tendon coming and inserting here, and there is new bone formation. And what inserts here? Plantar fascia. And that's why you can see that very fluffy periosteum. Look at the outline of the bone here, very sharp. Look at that. It become very somebody has used a brush to draw this outline. So this periosteal reaction or reactive change is typical of seronegative arthropathy. It can occur at any enthesis or at any attachment. Okay, so seronegative arthropathy is disease of which part of the joint? Which part of the hand, sorry. Proximal, distal, mid. Very good. So we can easily differentiate that it is the main disease of distal part as compared to rheumatoid. It can involve MCP joints, it can involve PIP joints, but it is the mainly disease of distal part of the hand as compared to proximal part of the hand. Very good. Let's leave that. Okay. Okay, this is the main. Okay. It can be bilateral, asymmetrical, it can be unilateral. Okay, and sometimes it can lead to DI, multiple joints in one finger can be involved. And as I said, DIP joint involvement can be common. So if you see something involving the DIP joints, so it can be gout, it can be seronegative arthropathy or erosive arthropathy. That's what we discussed before. The same thing, just revision of the same thing. That distal joint involvement can be seen in seronegative arthropathy. Don't say psoriasis, seronegative is the best word. Now, in this case, you can see that there is sausage finger. Although you can't see any bony changes, but this finger is inflamed. It means multiple areas are involved in one bone. You can see multiple areas or multiple joints can be involved in the bone as well. Now, look at the erosions now. Periarticular erosion. Look at that. Compared to erosion we saw in erosive osteoarthritis, they were sharp. We said bony outline will be sharp. Look at that. So fluffy. So fluffy. But it's not in the joint. Look at that. What inserts there? Capsule. Capsule coming here, capsule attaching there. Wherever the capsule inserts, there is a reactive bone formation. Okay, there may be erosion, there may not be any erosion, but look at that. How much the reactive bone formation at the attachment of the capsule. Look at that. Erosion, erosion. Both have significant fluffy periosteal reaction because it's the reactive bone formation, which is a hallmark of seronegative arthropathy. So this is enthesopathy, reactive proliferation. Okay, look at another. Looks like in the first instance, looks like it can be erosive arthritis or Siegel sign, a bit more flat. Look at that outline of the bones, even outside the bone, because some tendon may be attaching there, because at the attachment, outline of the bone, look at the outline of the bone in the joint is so sharp, but where the attachments occur, it is so fluffy. So it is called as whiskering, it is called as fluffy periosteal reaction, fuzziness, it's the same thing. Gout has a very sharp margin. Gout doesn't have that fluffy periosteal reaction. Okay, so fuzzy, whiskering, thickened cortex, because when this periosteal reaction keep on happening, it can lead to thickening of the cortex and increase in size of the bone. Why it is important, I'll come back to that. Okay, look at that. Although bone margins are sharp, but this pencil and cup appearance in the DIP joints is typical of seronegative arthropathy. Although this is not very commonly seen now because patients are treated very quickly. Look at that. This looks sharp, but look at that one. There is very fuzzy periosteal reaction in this area. Okay, and look at that. Pencil and cup there. Look at the periosteal reaction. Everything else we discussed had a very well-defined margin. Okay, so this is very typical of seronegative arthritis. So what I do when I come across these things, I suspect there is seronegative arthritis, I mag it as much as possible and look at the sharp outline, look at the cortex and compare with the area concerned. Okay, let's have a look. What's happening here? Which bone is fluffy here? Pisiform. Okay, good. But why pisiform is fluffy? It is thickened. I agree. It looks fluffy outline. Yes, it is basically a sesamoid bone. So it is present in the tendon. So it has proximal attachment and distal attachment. So it is in the tendon. So it has two attachments, and both attachments have inflammation. And that's why pisiform becomes bigger, because there's an inflammatory reaction. And that periosteum give this appearance of increased size of the bone, which can be seen in the bones, in the seronegative arthritis. I'll show you a few more examples. So sesamoid, because sesamoids are embedded in the tendon, so inflammation is much more. So, pisiform is the sesamoid bone. Momal asks about this. Okay, just want to repeat this point. Sesamoid bones are basically accessory bones. They develop in the tendon. So basically, they're surrounded by the tendon. So there will be inflammation all around the tendon, because tendon is passing between wherever they're touching. So they are surrounded by inflammation, and there's a reactive new bone formation or periosteal reaction, give the increase in the size of the bone, and especially in the sesamoid bone, and the bone become bigger. They look bigger, and that's why yeah, it can do in patella, but patellar involvement is not very common in seronegative arthritis. Hands are much more common in. Okay. So in the wrist, what part is commonly involved in seronegative arthropathy? Any part can be involved basically. Pen compound. Can be asymmetric, but main thing is the same thing. But in the beginning, osteoporosis is not as common as that of osteoporosis. So rheumatoid is, I think, wrist involvement is much more common as compared to seronegative arthritis. Right. So in the feet, what do you think? Which part is mainly involved? DIP joint, somebody said it already. Yeah, always start distally. Okay. Again, same thing, asymmetrical, multiple joints in the same toe can be involved. Okay. MTP joints can be involved. Okay. But main thing you remember, there's more destruction of the DIP joint or interphalangeal joint, or fusion as compared to rheumatoid arthritis. Okay. If you see any fusion, think of seronegative arthritis. So this is how we come across. So this is a magnified view. Where is the abnormality? I'm sure you cannot see. Look at the bone here. Nice outline. Let's start looking here. Nice. Start seeing this periosteal reaction here, isn't it? There's a periosteal reaction there. Very fine outline there, but if you come to the base, we can see the periosteal reaction on both sides. Same thing, oblique X-ray. Periosteal reaction, because this is the area of attachment of the joint capsule. So this early fuzziness is typical of seronegative arthropathy. Somebody asked how you identify osteopenia. You have to see a lot of X-rays. You have to set your eyes on osteopenia. Okay. Now, same thing, similar. Okay. Can see that there is fluffy periosteal reaction, egg and cup appearance. What is this? Sesamoid bone. Sesamoid bone is usually not like this. It is usually well defined, but because of multiple erosions or enthesial periosteal reaction, it has gone bigger and become irregular in outline. Similar thing, the fluffy periosteal reaction. It's typical of seronegative arthritis. Okay, the pencil cup appearance, erosion of the sesamoid bone. So what is a summary? It can be bilateral, but it's asymmetrical. Single digit, it can be multiple joints can be involved, or there can be soft swelling, can give the sausage appearance or swollen finger. Yes, of course, it can occur anywhere. Sausage finger can occur in the foot. So distal joints are involved, with bone destruction. As I said, distal disease of distal, but main thing is this thing. Think of whiskering, fluffy periosteal reaction, cortical thickening with irregular outline, and enthesopathy. Wherever the attachment is, they should be fluffiness, as I showed you example of Achilles insertion. And bone enlargement, especially the sesamoid bone, and they can be fusion. Fusion is more common than any other arthritis. So that is the end of it, but we just do one more thing to do. We just go and try to revise it here. So what is osteoarthritis? So I just want you to can everybody hear me now? I think somebody said that you can't hear me. Probably I'm getting tired. It's fine. Okay. Okay. So osteoarthritis, come back to that. What are the main points? Very good. Basically, it's a disease of distal part of the joints, okay? This part of the hand, MCP joint, bone density, but what are the important negatives? Yeah, doesn't involve the radiocarpal joint. And in the MCP joints, no spurt, no osteophytes. And somebody mentioned before, one thing I've forgotten about, just you're going too fast. Yeah, and the bone outline is sharp. Very good. Okay, very good. IP joints are involved, distal, second and third MCP joint with reduced joint space, but no osteophyte. Radiocarpal joint is spared. Okay, and of course, margin is very sharp. Okay, moving to erosive change. Erosive osteoarthritis. What is the distribution? Same as that of osteoarthritis, very good. And we see what is the main hallmark of articular surface irregularity, very good. And but margins are sharp, very good. And distribution, and what else we look in the wrist joint? TF, yeah, STT joint and first CMC joint osteoarthritis, and commonly seen in which gender? Elderly female. Excellent, excellent, very good. Okay, same thing, just a revision there. Marginal osteophyte, central collapse, sharp bony margin. That's the main thing. Look for STT joint and first CMC joint osteoarthritis in elderly females. Very good. Now, CPPD. What is the distribution? In hands or wrist. Radiocarpal joint. Second and third MCP joints. What is associated with it? Yeah, calcification. Hook osteophyte in the MCP joints and radiocarpal joint. Okay, and we see all four. Then we should think of, yeah, somebody said slack, very good, because there is a scapholunate gap and they can lead to slack, very good. And if you see all of them, then it is hemochromatosis, very good. Okay, let's recap. Calcification is the main problem here, especially in the cartilage. Second and third MCP joint, but now with osteophytes. Radiocarpal, which plus minus slack. And if all MCP joints involved, think of hemochromatosis. Now, gout. What is the distribution in hands or wrist? Any, yeah, absolutely, all joints. Okay, it can involve DIP, very good. Okay, and we know erosions, very good. Erosion are all types of erosion. We know it can calcification, tophi, asymmetrical soft tissue masses. And what about in the wrist joint? What is the hallmark? Very good. Bony density is generally normal in acute case. Large erosion in the metacarpal and metatarsal bases. That is the main take-home points. Okay. Okay, that's it. Any joint can be involved, including the DIP joints. Typical punched out erosions. Asymmetrical soft tissue masses, pen compartment, but we should look for large erosion in the metacarpal bases, and same thing in the foot. Rheumatoid arthritis. This is a disease of synovium or synovitis. Okay. So you can say bilateral symmetrical if you want. Okay. Osteopenia, very good. Erosion, very typical. And it involves proximal part of the hands. And erosions start where in the hands? Ulnar side, ulnar styloid, triquetral. Okay. And in the foot, commonly seen in fifth metatarsal base. Excellent. Very good. Okay. Bilateral symmetrical, periartical osteopenia, proximal part of the hands, MCP and PIP joints, wrist pen compartment, ulnar sided erosions. That's where we start. In the foot, we can see both sides of the fifth MTP joint. That's where these early erosions start. But main thing is there's no periosteal reaction. They can be ill-defined, but there is no periosteal reaction. Okay. Right. Seronegative. What is the summary? What is the hallmark? What is the main problem here? Yeah, enthesial inflammation or enthesitis. Okay, so that's why you need to look at. It can be marginal, but should be fluffy periosteal reaction. Very good. Distribution, proximal, distal. Distal, mainly distal, can involve proximal, but mainly. And it can be a unilateral, bilateral, just one digit, lead, go to sausage digit. Okay. But main thing is you're right. Fluffy, whiskering, periosteal reaction, bone enlargement, and bone fusion, penicillin cup as well. Very good. Attachment of capsule, ligaments, tendons, whatever. So can be unilateral, bilateral, asymmetrical, single, multiple joints involved. Distal joints are also involved with bone destruction, whiskering and fluffy periosteal reaction, enthesopathy, and bone enlargement and fusion. Now, you don't have to differentiate, Gagan, between any one of these. They all just say seronegative. It's not our job to differentiate between any one of these. So just, I don't even say psoriatic arthropathy, I say seronegative arthropathy. You don't have to. Okay. Any question? Recording, I think Dr. Sami will answer this question when this be uploaded. So tubercle arthritis is same as that of um, infective or septic arthritis. So ankylosing spondylitis doesn't involve hands. So I think we have to do another talk sometime for axial um, or axial arthritis. So ankylosing spondylitis usually doesn't affect the hands. So this is just to, that's why I did not mention ankylosing, because it starts in the SI joints and spine. So this is slightly different, but I'll probably do another talk sometime for that part at some other time, inshallah. So Sami, should we have a time or should we stop here? I'm a bit tired, to be honest. But yeah, if there's any thirst, I can.
Say again, please.
Should we do some cases or should we stop here?
No, no, I think there is a candidate waiting for you.
Okay,
So
okay, that's fine. Let me just.
for the last 2 hours, if the candidate is there, you must give some cases.
Okay,
Uh, so, candidate one, are you with us?
Yes, sir.
Yeah, so the candidate is there, so we must give him.
okay, that's fine.
He,
Okay,
he has waited 2 hours.
okay,
Okay.
okay. So there's a question, how often the combination of different arthropathies is presented in Vivas? I have no clue. So Sami may be able to answer it while I bring cases up.
Sorry, I how often a case combination of different arthropathies is presented in Viva? It is a very important case, by the way. I don't know if you combination of arthropathies means multiple arthropathies. That if you mean that, that is unlikely. Secondary OA, of course, can happen with RA if you mean that. There definitely, but if your question is simple, are arthropathies important for the FRCR exam? Yes, with a capital yes. So it is very, very important. So over to